All righty. Let me pull the PowerPoint here. Okay. My computer exited out of PowerPoint, so give me just a second. Technology is being very helpful today. At least we all have Canvas access. We didn't have class on Thursday and have to try and deal with all of that. I don't know if you guys heard about that from others.
Are you going to post the exam reviews once they're done?
Yep, just like I did last time. Yep, just like I did last time.
It'll be under announcements.
It'll be under the announcement that has all of the exam 2 material and the schedule. Yep.
Okay, perfect. Thank you.
Yep. And some of them won't potentially have them if they didn't do an exam. Like if they didn't have students show up, we don't do exams reviews. If no students show up, we don't do one. We don't just do it for nobody. So sometimes if there's not a link underneath of a professor's name, it's because no one attended. Okay. But yep, as soon as I get them, I will put them on there. Selena, your camera is still not on. I'm going to ask you to turn it on or you're going to have to leave class. Okay. Okay. All right, you guys should be seeing my screen now, hopefully. Okay, can you all see that? Yes? No? Maybe? Okay.
Yes.
Okay, thank you. Okay, so we'll go ahead and get started. This week is hematologic and immunologic dysfunction, chapter 43 is where we're going to start, okay? If you guys have any questions, just unmute and ask. Okay, so what's involved in hematologic and immune dysfunction? So some labs you're going to be looking at are CBC counts, okay? And we'll go into those more specifically as we talk about the different types of anemia, okay, and kind of what to expect. You're going to be taking a history and a physical exam. You know, you might be looking at a kiddo if they're having hematologic problems. They might be pale, they might have a lot of bruising, they might have prolonged bleeding, they might be really fatigued. Just kind of looking into some of those symptoms that you might be noticing. Okay. So the reason why you usually see pallor or fatigue in kids with hematologic conditions is because they have low hemoglobin and hematocrit. Okay. A lot of times you'll have these kids keep food diaries, especially if you're concerned about like an iron deficiency anemia, which is the most common cause of anemia in kids. Okay. Seeing what they're eating. Are they having a lot of dairy? That can contribute to declining their iron stores further and worsening their iron deficiency. So keeping track of that, or, you know, are they eating any green leafy vegetables or are they eating any red meats? Okay. These kids are also, because they have immune dysfunction, they're going to be more prone to having frequent infections. Okay. And then if they have hematologic dysfunction, of course, they're more prone to bleeding. Okay, so anemia, the broad term of anemia is just decreased number of red blood cells or a lower hemoglobin. Okay, you can have some anemias with a normal red blood cell count, but a low hemoglobin. Okay, so it can be kind of any combination. You can have normal red blood cells and a low hemoglobin, or you can have both low hemoglobin and low red blood cells. Okay. Decreased oxygen carrying capacity on those hemoglobin molecules. Okay. You look at your morphology, that's going to be the changes in the characteristics of the red blood cell shape, their size, their color. Okay. Can be kind of any combo of those options. Usually to diagnose anemia, your hemoglobin is going to be lower than 10 or 11 grams per deciliter. Okay, that's like typical adult range. Now for children, the hemoglobin level can kind of vary based on their age. Okay, so like a lower hemoglobin might be more acceptable in a younger kiddo. Okay, so in looking at so hemodilution is one option for a type of anemia. So if there's a lot of extra fluid in there, diluting the amount of red blood cells that you're getting, that can cause a form of anemia. Okay. So that can make your red blood cell count decrease and your hemoglobin be lower because of the dilution that's going on. So if kids are getting IV fluids, sometimes you'll see, a drop in the red blood cells potentially. Okay. Decreased peripheral resistance can cause or can be caused from anemia. Increased cardiac circulation and turbulence, so a potential for a murmur to occur because of the anemia. And sometimes if anemia continues and there's no intervention, that can cause cardiac failure. Okay. As anemia progresses, because of the decreased capacity for carrying oxygen throughout the body, you're going to see cyanosis and you're going to see growth retardation or a delayed slow growth. Okay, so in looking at the classifications of anemia, this slide is very helpful for you guys to kind of keep in mind while you're studying. Okay. So if you're going to have decreased red blood cell production, that kid's going to have pallor. They're going to have headache, tachycardia, fatigue, shortness of breath, murmur, and pica. Pica is eating different objects that are non-food objects. Sometimes paper, sometimes people will crunch on ice. You'll see that, like they're craving ice. Okay.
Does that mean they're anemic?
Yep, that's a sign of anemia. And so that is usually when you see pica, it's because they're having a decreased red blood cell production. Usually that's from a nutritional deficiency like iron deficiency anemia, folate deficiency, vitamin B12 deficiency, low copper, a chronic disease state, or chronic blood loss. Okay. You can also see decreased red blood cell production if there's bone marrow failure. So if they have a malignancy, so if they have some sort of cancer, or certain viral infections will cause bone marrow failure as well. Aplastic anemia or red cell aplasia. Okay. Increased red blood cell loss would look somewhat similar, but you're going to see some signs of shock. Okay, because of the red blood cell loss. Okay. Now, low blood pressure is going to be something, it's a later sign of shock, right? So you're going to see that later. So first you'll see decreased peripheral pulses, cool skin, tachycardia. So this is typically from an acute blood loss. So a trauma, hemophilia, epistaxis, so nosebleeds, hypersplenism, ITP, so idiopathic thrombocytopenia. We'll talk more about that. DIC. Okay. So that's usually going to be from like a trauma type scenario. Or you can see an increased red blood cell destruction. So they're making a normal amount of red blood cells, but they're being destroyed. So with that, you can see icteric sclera, which that's going to be kind of the yellowing of the whites of the eyes. Paler, darker urine because of the destruction of the red blood cells. You're going to see that through the urine. So they might have kind of like a blood tinged colored urine. They're going to have an enlarged spleen, usually a large liver, and also frontal bossing. Does anyone know what that means? So like a more prominent forehead, and prominent in the way that it's kind of bulging outwards. Okay. So there's two different types of red blood cell destruction. It's your intracorpuscular or your extracorpuscular. Goodness, I'm having a hard time. So your extracorpuscular is going to be with your immunologic dysfunction or your like substances, drug toxicities. So chemotherapy is one that causes increased red blood cell destruction. It actually destroys every type of cell in the body. And infection or radiation. Okay. Intracorpuscular is going to be your hemoglobinopathies. So beta cell thalassemia, sickle cell disease, G6PD, or hereditary spherocytosis. So membrane defects of the red blood cell that kind of then flag them to be destroyed by your immune system. Okay, so therapeutic management of anemia. Like I said originally, that your diagnosis is going to be based off your history and your physical exam and also CBC results. Okay. Sometimes you might also look at iron levels or some of those nutritional deficiency levels. So your folate, your B12, all of that might be something that's involved in looking into in the diagnosis of anemia. Treating the underlying cause is what is necessary for improving the anemia. So if it's from a nutritional deficiency, then that needs to be corrected. Okay. So if it's related to an iron deficiency, which, like I said, that's the most common cause of anemia in pediatrics, those kids need to be taking iron supplementation or eating more green leafy vegetables or eating more red meats and eating less dairy. Okay. Especially cow's milk. If kids are drinking, nonstop cow's milk all day and not drinking any water, then it's pretty likely that that kiddo will have iron deficiency anemia. Okay. Obviously, if their hemoglobin is very low, they need a transfusion. Okay. If there's some sort of trauma going on, they're having a hemorrhage, then they'll also likely need a transfusion. So creating or correcting the underlying cause. Supportive cares, IV fluids may be needed if it's an intravascular volume loss. Okay. So if it's a trauma and they can't get enough blood on board, then they'll utilize fluids as well. Okay. Oxygen may need to be given. Bed rest may need to be implemented because of the decreased oxygen that goes along with anemia. Okay. Good. Okay, care management. So looking at the age of the child and the background of the child, and then getting that careful history. You also want to check the stools for blood because sometimes, internal blood loss is also a cause of anemia. Okay. Going to have to work with this kiddo and the family on needing regular labs checked. Okay, so working through the fear of that and implementing, like, a numbing cream applied beforehand and child light for distraction, things like that. You're going to want to work with them on decreasing oxygen needs. So these kids aren't going to be super active kiddos when they're having their anemia flare ups. Okay. And then, of course, treating them so you prevent long term complications like heart failure. Okay. Iron deficiency anemia. So this specifically is caused from inadequate supply of dietary iron, whether it's from their diet or there's some dysfunction in their iron binding capacity. Okay. Generally, iron deficiency is preventable and correctable. Okay. So formula is iron fortified. Cereals like rice cereals and all of that are also iron fortified. So that helps to kind of bridge the gap of the natural anemia that happens from 6 months to a year in kiddos. Okay. They're also starting to eat more foods throughout this time. So making sure that they're getting plenty of green leafy vegetables. They're eating some red meats. They're not drinking a bunch of cow's milk. Like I said, a lot of times it's caused because kids are having so much cow's milk in their diet and they're not eating, a lot of green veggies at a year of age. Not all kids do. And then they're also not eating a lot of red meats to kind of correct that milk intake. Okay. So the goal is to increase the amount of iron that the child has either in their diet or by supplementing. The best way to supplement is dietary changes. If parents and kiddos will not comply with that, then they can take an oral iron supplement. Okay. Now, for iron supplementation to be beneficial and to actually work and be absorbed correctly, they have to take it with vitamin C. Okay. If they're not taking it with vitamin C, then it's not going to correct the deficiency. So they can take it either with a multivitamin with vitamin C or they can drink it with some orange juice. Most parents, I find, they just mix that liquid iron with some orange juice and the kiddo will take it. Making sure now iron, I don't know if any of you guys have done iron supplementation with your own kiddos. No? Yes? Maybe? So it's really dark in color. So it will stain if you get it like on your clothes or on your hands or on the kiddo's hands or face. So make sure you're wiping it off really quickly. And then you also want to brush their teeth because it can darken their teeth a little bit too. Okay. So the big thing with iron deficiency is have them eliminate dairy and improve their dietary intake of green leafy veggies, red meats, beans, legumes, things like that that are higher in iron. Okay, sickle cell anemia. This is another form of anemia. This is one of the hemoglobinopathies that we talked about. So what happens is there's either a partial or a complete replacement of your normal hemoglobin, which is a nice circular shape, with your sickled hemoglobin, so your hemoglobin S. Okay. It is an autosomal recessive, so they have to get both genes from parents. Okay. And it's more predisposed to those who are of African American descent. Okay. About 40% of Native Africans are carriers. That does not mean that they're affected. That would be sickle cell trait. Okay. If the kiddo gets the trait from both parents, then they're 25% likely to have the disease. Or excuse me, if both parents have the trait, then the kiddo is 25% likely to have sickle cell anemia. Okay. If both parents pass on the trait, then of course the kiddo will be affected. Okay. So the pathophysiology of sickle cell anemia, what happens is because of those sickled cells, you see an accumulation or a clumping of those sickled cells. So then that causes obstruction in vasculature. Then, as that obstruction continues to enlarge, you see vascular inflammation. And then, because of those sickle cells, you're also seeing increased red blood cell destruction. Okay, so red blood cells may be being made normally, but they're being destroyed because they're those sickles shaped. Okay. Now, anything after that obstruction is at risk for hypoxia and cellular death. Okay, so if this sickled vasculature obstruction is happening, within the brain, then that area of the brain after that obstruction is no longer getting the oxygen that it needs to function. Now, when that's happening, that's when you see sickle cell crisis. Okay. So sickle cell crisis is when the occlusion, so it's totally cutting off that vein, and anything after that obstruction is no longer getting the oxygen and the red blood cells carried to it. Most common causes for sickle cell crisis are trauma, infections, fevers, physical or emotional distress. So if these kids are playing really hard contact sports and they haven't adequately hydrated, then they're more at risk for sickle cell crisis. Okay. Hypoxia, so having low oxygen, or anything that affects or increases your oxygen demand can also predispose kids to having sickle cell crisis. Dehydration is probably the number one cause of sickle cell crisis in kids. Because what happens if we're dehydrated, we don't have good fluid reserves. So all of those sickle cells are just more likely to clump up. Okay. Sickle cell anemia is diagnosed on the newborn screenings in every state in the US. Okay. Sickle cell trait will also show up. Okay. So in treating sickle cell crisis, of course, you want to decrease those increased oxygen demands. So you want them to rest. You want them to improve their hydration status. So you want them to get IV fluids. Okay. Sickle cell crisis is very, very painful. So a lot of these kids are going to be on IV pain meds. Some of them are going to be old enough to have a PCA pump so they can use it on demand. Okay, if they're hospitalized in crisis. Heat can help. Replacing any electrolytes, that kind of goes along with the dehydration piece. Managing their infections, so giving them IV antibiotics. And then giving them blood transfusions if they're extremely anemic. Okay. That's kind of a fine line though, because you don't want to add too much blood volume to increase their risk of obstructions further. Okay.
Excuse me,
Kids,
Professor. Sorry. Selena says she's trying to like join the meeting.
she's trying to join back in.
Yeah.
Okay. Okay, hang on one second.